Hi Jodie, can you just start by introducing yourself and what you do at Nelson Tasman Hospice?
Kia ora, Donna. So my name is Jodie Battley. I am a medical doctor. I'm a palliative medicine specialist and the medical director at Nelson Tasman Hospice.
Fantastic. And can you just tell us a little bit about your professional journey to where you have come into Nelson Tasman Hospice?
Sure. I'm an Otago graduate. I had an interest in palliative care right from an early stage as a junior doctor, and I actually travelled to Ireland to get some international experience. I ended up staying there for 11 years, having gone for 6 months, and just fell in love with the place. And I trained there in oncology and palliative medicine. I finished my specialist training there, and by that stage I was really ready to come home. And I jumped at the chance when I saw a job come up in Nelson, because where else would you want to live and raise a family?
Fantastic. So you actually travelled back for this role?
Absolutely.
Oh, that's fantastic. And having that international experience about specialist palliative care and coming back into New Zealand, tell us a little bit about that.
Yeah, so I think that certainly in Ireland, palliative care is better represented at a national level, at a ministerial level, and I think better resourced. So, you know, certainly the services there were very well developed. So I've worked in lots of different models in Ireland, which I think has been very helpful. And of course, there's not always the right fit. You know, we have to think about a New Zealand context, but certainly have brought a lot of experience to NTH.
How lucky are we? So can you just explain that term specialist palliative care, which I'm learning more about? Can you just explain what that means in terms of Nelson Tasman Hospice and its services?
Sure. So palliative care has really evolved over the last 50 years or so, from care that was very much focused at the very end of a person's life, in their last days, to being a highly specialised field, which really supports a patient from diagnosis of life-limiting illness throughout the disease trajectory and right into bereavement. So our care can be appropriate or relevant for people from diagnosis, certainly weeks, often months, and sometimes even years before they die.
That's one thing that I'm really learning a lot about, is something that I think is one of the myths that people believe, that hospice is this place in Suffolk Road, this lovely facility, but it's the reach that we do within the community and for the length of time, isn't it?
Yes, that's right. I think it's really important to explain that not all patients will need to see the specialist service. So we know that for many patients who have perhaps non-complex needs, have those needs very well met by their GP or other providers with our support, and we spend a lot of time doing that. There are patients who need to see us throughout their journey intermittently, perhaps for flares of symptoms or to have difficult discussions around decision making, but then go back to the care of their GP. But there are others who have the most complex needs, who really we need to walk alongside them for their whole illness until they die. And those are the patients that we're really focused on. I think by, you know, in the context of limited resources and increasing demand for palliative care, we have to base our service on what the complexity of the case is, what the needs of the patient are, and only by doing that can we make sure that those who really need us the most can access our care.
So Jodie, can you just explain for me what your role is in the work? I know that we have a team of about 60 in our clinical team in terms of our colleagues, so can you just explain what you do?
Sure. So I work in the community. I work in the hospice inpatient unit at Suffolk Road, and I work in the hospital. And my role is really to support patients with life-limiting illness and their families to live as well as possible, as fully as possible until they die. So a lot of my role is around complex symptom management, so dealing with things like pain. And actually, I think pain is one of the things that people fear the most, but is one of the things that we're actually best equipped to manage. First and foremost, I spend a lot of time talking to people about what to expect, what lies ahead. And that includes talking about what it's like to die. It's not something we talk about very often as a community. And actually, it sounds really confronting, but people really want to know, and they get comfort from that. So I help people to plan. I help them to manage their expectations and to articulate what's really important to them. People don't always know what their choices are, or in fact if they have choices, and so having those conversations up front and early with people makes it much more likely that we can deliver the type of care that people want at the end of their life.
We just talked with Simon Starr, and through his direct connection with his wife Alison, he talked about those conversations and how important it was for them, for Alison, and also for the family.
Yes.
You said at the start, Jodie, that from an early on you realised that you were interested in palliative care. Can you talk about why your interest started there?
I think my interest in palliative care was multifactorial. I had a friend who died far too young when we were going through medical school, and so that started things off for me, I guess, and she was the one who said, "You're going to end up here." And she was right after a long path. But I guess I've seen how not to do it as well. I remember very clearly a moment following a doctor around on his rounds in the medical ward round in the hospital, and him walking right by a patient's room and saying something like, "Let's focus on the living." And I remember that woman's relative who was sitting beside her and holding her hand, looking up with such hope that we were going to come in that door, and all I wanted to do was go back. So yeah, some poignant moments, and I guess I've seen the side of it, how well things can be done, and the fact that there is always something that we can do to ease suffering, even at a time where people feel that all is lost.
Yeah. What do you love most about your work, and the work that I suppose in general hospice does throughout the Nelson Tasman community?
I think for me it's about being able to make a difference at a time that's so important to people and their families. I think it's extraordinarily gratifying, actually. I get asked all the time, how can you do this? Isn't it depressing? And actually I can tell you truly it isn't. It's certainly not a one-way street. We get so much back. It really is a time where there can be great connection and growth and healing. And I think for me that brings great meaning, personally and professionally. I think we also need to, be careful to look after ourselves and after the team. There will always be sad cases. There are hard cases that you carry with you. But I think we're pretty good at reflective practice and debriefing and looking after the team.
So Jodie, can you just explain a little bit about the team that you have and that you work with at Nelson Tasman Hospice?
Sure. So, like you say, we work very much as a team. We know that the impact of life-limiting illness for patients and their whānau is much further reaching than just physical symptoms. It impacts people emotionally, of course, socially, on their relationships and their roles, and spiritually. So to truly address the needs of patients in every aspect of their illness and every aspect of their lives, we need a team around us to do that. So we need the expertise of our nurses and doctors, of course, but we also need our skilled social workers, our therapists, and our spiritual support team. We really provide a wraparound service at hospice, and we put the patient and their family right at the centre of that.
And if there was a myth that you'd like to dispel about hospice services in the community, what would that be? You can have more than one.
Okay. So I think for me, I think there's still quite a misconception out there that hospice is only for people who are imminently dying, so at the very end of their life. And I think that's not only in the public, but also for our own colleagues. We still get referrals far too late. When we know from multiple studies and from our experience that the earlier we can be involved, the more impact we can have, the better the outcomes for patients and their families. I think there's still a belief in the community as well that the hospice inpatient unit is a place that you go to die and you never come out of. And so I can tell you that that's not the case. When we look at our data from last year, for instance, 80% of our admissions were for symptom control. So those patients come in for a reasonably short period of time to have a tune-up, and then once they're safe to go home, they go back into the community, which is of course where people want to be, and actually where most of our care is delivered.
That's one of the, when being introduced to the service, looking at some of those statistics is overwhelmingly it's a specialist place to come and like you said, get that complex symptoms controlled or managed and then back into the community. And so taking the service to the community must be something that is really special and humbling, being able to go into the homes of people and get to know their whānau as well.
Absolutely, it's such a privilege to be able to see people in their own homes and to be able to help people to stay at home for as long as possible and to die at home if that's what they wish for.